Good morning, everyone. Yesterday, as most of you were not there, I am summarizing acute kidney injury and nephrotic syndrome. Acute kidney injury. What is acute kidney injury? Acute kidney injury is the renal dysfunction occurring in hours to days, which leads on to extravascular volume expansion. Kidney failure occurring hours to days, leading on to renal kidney function dysfunction is there, which leads on to extravascular fluid expansion because water is not excreted out, and then the electrolytes like potassium and acids H plus is excreted in the urine. If they are not excreted, they will get accumulated. So there is increase in potassium and acid levels, that is hyperkalemia and NAGMA, normal anion gap, metabolic acidosis will be there. The other feature is uremia. We all know that when kidney fails, there will be uremia. This is the definition of AKI. The most important definition than this definition is KDIGO classification. KDIGO has given 3 criteria to classify a patient as having AKI. Those are according to urine output and creatinine. Urine output, coming to urine output, if a patient has less than 0.5 ml per kg per hour for more than 6 hours, if the urine output of the patient is less than 0.5 ml per kg per hour for more than 6 hours, and it's associated with rise in creatinine levels more than 0.3 mg per dl in 48 hours or more than 50% in 7 days, it's considered as AKI. The prerequisite is we should know the patient creatinine level 2 days before or 7 days before, which is not the usual clinical scenario. The 2 and 3 are simple. We can clinically apply this. The urine output less than 0.5 ml per kg per hour for more than 12 hours, associated with rising creatinine more than 2 times the baseline, is considered as AKI. And also KDIGO3 says that less than 0.3 ml per kg per hour for more than 24 hours, or anuria, that is less than 100 ml per hour for more than 12 hours, associated with rise in creatinine levels more than 3 times the baseline, is considered as AKI. So this is classification of AKI. Sorry, definition of AKI. Acute kidney injury. Also, the normal urine output is 0.5 ml per kg per hour. Let's continue. First, going on to etiopathogenesis. The acute kidney injury can occur because of prerenal causes, renal causes, and postrenal causes. Prerenal causes are reduced intravascular volume. What is reduced intravascular volume? The blood level is reduced. The blood volume is reduced. It may be due to acute hemorrhage following road traffic accident or other causes. Maybe due to acute GI blood loss like upper GI bleed, hematemesis, that is secondary to portal hypertension, or vomiting, diarrhea, or renal causes like increased dosing of diuretics, injudicious use of diuretics, diabetic insipidus. We'll discuss what is diabetes insipidus in coming sessions. And these are the causes where intravascular volume is reduced. What are the other causes where effective intravascular volume is reduced? Effective intravascular volume is reduced means the amount of blood inside the body is normal, that is around 5 liters. But the amount of blood inside the blood vessels is reduced. It may be due to third space fluid loss, like in case of nephrotic syndrome, burns, rhabdomyolysis, and other causes. You can remember 2 to 3 causes and continue with this. So now we discussed in etiopathogenesis, we discussed prerenal causes that are reduced intravascular volume and reduced effective intravascular volume. Let's go on for renal causes. Renal causes, yesterday we discussed extensively the etiopathogenesis of ATN and AIN. So today I'm not going in depth because it's a summary video. Let's see briefly. What is ATN? ATN is acute tubular necrosis, meaning the PCT is damaged. What are the things which damage the PCT? It may be due to ischemia. The ischemia due to prerenal cause can lead on to acute tubular necrosis. Due to reduced blood supply, there will be reduced blood moving through glomerular capillaries, glomerular tuft, and then efferent arteriole, and then efferent arteriole continues as peritubular capillaries. When there is reduced blood supply to kidney, there will be reduced blood in peritubular capillaries and thereby reduced perfusion of PCT. Proximal convoluted tubule, distal convoluted tubule, loop of Henle, and all. So this leads on to ischemia and necrosis of the epithelium, which lead on to acute tubular necrosis. Okay, this is ischemia leading on to acute tubular necrosis, and other important causes, toxins leading on to acute tubular necrosis. Toxins may be endogenous or it may be exogenous. Endogenous toxins are hemoglobin. We know that hemoglobinuria leads on to acute kidney injury through acute tubular necrosis. That is hemoglobinuria, myoglobinuria following rhabdomyolysis, increased uric acid level in tumor lysis syndrome, and increased excretion of light chains of antibodies. So, what are the exogenous causes of ATN? Exogenous toxin leading to ATN, acute tubular necrosis. Those are drugs and contrast. Radio, radio contrast used in radiological examination can lead on to ATN. And the few important drugs are uh, cisplatin, aminoglycoside, and then other drugs are there. I'll update you the list. Okay, what are the, these are the, this is the pathogenesis of ATN, that is ischemia and toxins, that is exogenous and endogenous, leading on to acute tubular necrosis. What are the clinical phases of acute tubular necrosis? There are three clinical phases, that is tubular injury, followed by tubuloglomerular feedback, and then followed by recovery. During tubular injury, there is increased excretion of water and solutes because the epithelium is damaged, that is PCT, tubular epithelium is damaged. This leads on to increased permeability of water and solutes through the tubule, and it's excreted in urine. That is phase of tubular injury. When there is phase of tubular injury and increased excretion of water and solutes, it leads on to activation of tubuloglomerular feedback mechanism. Extensively, yesterday I discussed tubuloglomerular feedback mechanism in case of increased GFR and reduced GFR. Now I can't do this because of time constraints. Let's go on. Tubular glomerular feedback. I will mention it briefly. So following this injury, there is increased excretion of water and solutes. This is sensed by macula densa, which leads on to increased activity of sodium channels. This leads on to decreased adenosine. This adenosine leads on to, I mentioned it wrongly. Increased sodium channels activity leads on to increased adenosine level, and this causes constriction of renal afferent arteriole, which reduces the GFR, thereby making the GFR less compared to normal. So this reduced GFR leads on to reduced urine output. Please remember, acute tubular necrosis is associated with reduced urine output. Then after tubuloglomerular feedback, when the toxins and ischemia, the causes leading on to acute tubular necrosis are gone, the tubules will recover and the patient will have normal function of the tubules. Then we have acute interstitial nephritis. Acute interstitial nephritis is most commonly due to type 4 hypersensitivity reactions following drug intake and some viral infections. It's treated with steroids. We can see, I'll discuss about acute interstitial nephritis in deep in following sessions. Next, we have post-renal causes. Post-renal causes are mostly surgical, like stone obstructing the ureter, and then prostatic enlargement leading on to prostatic urethra obstruction, and secondarily it leads on to AKI, and then we can have any tumors blocking the passage, urine output. It's lead on to post-renal causes. This is purely surgical. Then coming on to clinical manifestations. Clinical manifestations I have divided into two parts. First one is general, and second one is related to the cause. Let's see the general clinical manifestations. General clinical manifestations are due to impairment in kidney function. First one, increase in extravascular fluid, that is increased extravascular fluid expansion, leads on to fluid accumulation, and it causes increased JVP and crepitations due to pulmonary edema secondary to AKI. There may be increased uric acid level. Uremia leads on to GI upset, vomiting. The patient may experience vomiting, diarrhea. The patient may experience mental clouding and may also have bleeding manifestations due to impaired activity of platelets. What are the signs associated with uremia? That is asterixis, that is flapping tremor. When the patient stretches out its hand, he will have flapping tremors. Then we have acidosis and then hyperkalemia. Hyperkalemia leads on to ventricular arrhythmia. So we should look out for this complication and treat adequately as soon as possible. Then we finished with general manifestations. Then we have clinical manifestations related to cause, meaning in the prenatal cause, if there is portal hypertension and cirrhosis leading on to AKI, the patient will have features of cirrhosis like spider nevi, and then other manifestation, caput medusae, etc., etc. And if the patient has cardiac failure, right heart failure, you will have the features of right heart failure like edema, peripheral edema, and then hepatomegaly, and other things, and other signs and symptoms we all know. And also in renal cause, we already discussed. In post-renal cause, the patient in post-renal, sorry, not in post-renal, in acute interstitial nephritis, since it's a hypersensitive reaction, the patient will characteristically will have rashes. Rashes will be present, and the patient will have eosinophilia. And in case of post-renal causes, the patient will have history of urinary urgency, incontinence, other features of prostatic enlargement, and features of stone obstructing. That's acute. Patient may present with acute abdominal pain due to the stone obstructing. And related to other cause, we have so many things. You can elaborate on it related to cause. We are taking pre-renal, renal, and post-renal as a broad terms. You can explain the causes, the clinical manifestations related to causes. These are about clinical manifestations. Now we discussed definition, idiopathogenesis, and clinical manifestations of AKI. Let's proceed on to investigations in acute kidney injury. First, what are the renal investigations that we perform? We usually see blood, serum creatinine and serum urea level, and we'll calculate urine output because it's the defining criteria of AKI. Then we can see blood electrolytes level. There's characteristically increase in potassium, hydrogen, magnesium, and phosphate levels. And there is decrease in sodium and calcium levels. Decrease in calcium level is secondary to increase in phosphate due to PTH release and all. PTH and the calcium homeostasis, which we'll discuss in coming lectures. Decrease in sodium level is due to excretion in urine, and also excretion in urine, that is it may be due to excretion of water and solutes during tubular injury. Yes, let's continue. This is blood we saw serum creatinine, urea, blood electrolytes level. Then we'll go on to see casts, renal casts. On urine microscopy, we'll see casts. The basics of casts we discussed yesterday, but today we'll see in the future class. We'll take up this separately. And also we'll see urinary microalbuminuria, urinary protein excretion. There may be mild proteinuria due to the glomerulonephritis or other causes leading on to AKI. That is, it may be mild proteinuria up to 1 gram per deciliter leading on to AKI, or also there may be nephrotic range proteinuria leading on to AKI because the effective intravascular volume decreases in case of nephrotic syndrome, which leads on to AKI. So proteinuria can be mild or it may be nephrotic range because nephrotic syndrome is one of the causes of AKI. Let's go on for treatment. Before going off on treatment, let's discuss complications of AKI in brief. What are the metabolic complications? Metabolic complications we already discussed. There are increased levels of certain electrolytes and decreased levels of certain electrolytes. Increased electrolytes are phosphate, magnesium, hydrogen, that is acidosis, NAGMA. Decreased levels of electrolytes are calcium and sodium. Hyponatremia and hypocalcemia should be addressed. I missed the most important one, that is potassium. It is the most important one. Hyperkalemia should be looked out for and treated with calcium gluconate IV infusion. Okay, these are the metabolic complications. What are the serious complications? Serious complication is hypertension due to secondary activation of RAS system, renin-angiotensin, aldosterone system. What are the GIT manifestations, GIT complications? We know due to uremia, there may be GI upset, diarrhea, vomiting, etc. And also, the CNS symptoms are mental clouding due to uremia. That is uremic encephalopathy may be there. There is increased risk of infections due to impaired function of leukocytes, which so the patient may develop secondarily pneumonia and sepsis. These are in brief about complications of acute kidney injury. Let's see what are the how to treat acute kidney injury. The management of acute kidney injury. Management of acute kidney injury is first one, management of fluid overload. The fluid overload should be managed by restricting the salt intake to less than 2 gram per day, and then we can use judicious, and then wait for a second. I'll try to recollect. The fluid management. Fluid management is very important. We can treat the patient with fluid management. Fluid management I'll discuss at the last in textbook. I'm not able to recollect all the points for now. Let's discuss how to treat the complications. Okay, yes. Fluid management. We should give less than 400 ml of fluid per day. Along with that, the amount of fluid lost per day. This is about fluid management. And we should maintain serum sodium levels. And in case of hyperkalemia, we should give calcium gluconate. In case of acidosis, we can give sodium bicarbonate IV. And also to manage what are infections, we can give antibiotics. And also we should treat the cause. We should diagnose the cause and treat it. If there is any drug causing ATN, stop the drug. If there is if there is post-renal cause of AKI, go ahead with surgery. Remove the obstruction. If there is RPGN, that is rapidly progressive glomerulonephritis, we can manage the patient with steroids. We'll discuss about RPGN in following. If all the measures fail, at last we can do hemodialysis. Next, going on for glomerular disease. Glomerular disease, we have nephrotic syndrome. What is the definition of nephrotic syndrome? We have two important syndromes in nephrology, that is nephritic and nephrotic syndrome. Nephritic syndrome we will discuss afterwards. Let's discuss about nephrotic syndrome. Nephrotic syndrome, all the three criteria should be fulfilled. In case of adults, in children, 1 + 2 or 3 should be fulfilled. Let's see what are they. In adults, all these three criteria should be maintained to classify them as nephrotic syndrome. That is nephrotic range proteinuria, more than 3 milligram of 3,500 milligram per 24-hour excretion in urine, protein excretion urine, or urine protein to creatinine ratio more than 3 gram per gram in adults and more than 2 gram per gram in children is considered as nephrotic range proteinuria. In children, we also have the criteria. This is in adults, that is more than 3,500 milligram per 24 hours. In children, more than 50 milligram per kg per day is considered as nephrotic range proteinuria. Associated with this, the patient will have hypoalbuminemia. When there is protein excreted in urine, there will be hypoalbuminemia. That is less than 3 gram per deciliter due to loss of proteins in kidney and reduced hepatic compensation. We'll see how these things occur in etiopathogenesis. First, see the criteria. First, then we have edema. Due to hypoalbuminemia, then we must have edema. Due to reduced oncotic pressure. Oncotic pressure is responsible for maintaining water inside it pulls the water into the blood vessel. If the oncotic pressure is reduced, the water goes out of the blood vessel. That's it. So there may be edema due to underfill and overfill mechanisms. If these three criteria are fulfilled, in adults, we consider it as nephrotic syndrome. In children, if the child has edema or criteria 1 + 2, we consider them as having nephrotic syndrome. What are the causes of nephrotic syndrome? In adults and children, it's different. In children, the most common cause of nephrotic syndrome is minimal change disease, followed by FSGS, that's focus segmental glomerulosclerosis, and then IgA nephropathy, that's membranous nephropathy. 85 to 95% of them is due to minimal change disease. and then remaining 5 to 10% is due to FSGS and IgA nephropathy. What happens in a minimal change disease? The T cells will attack the podocytes. It causes podocytes injury, and then it leads on to increase in pore size, which leads on to proteinuria. In FSGS, there is glomerulosclerosis scarring, leading on to increase in pore size and proteinuria. In IgA nephropathy, there is immune attack to the glomerular basement membrane, impairment of function of basement membrane, leading on to proteinuria. What are the causes in adults? In adults, we flip the third and the first one. The most common cause is membrane of nephropathy or IgA associated nephropathy. The second most common FSGS, and third is minimal change disease. In adults, the nephrotic syndrome may be secondary to MPGN, that is membranoproliferative glomerulonephritis, or due to amyloid deposition. What are the clinical manifestations? We discussed about criteria and idiopathogenesis. Idiopathogenesis in adults and children. Let's see the clinical manifestations. What are the clinical manifestations seen in both children and adults? The most common clinical manifestation is anasarca, that is generalized edema. Associated with that, ascites, pleural effusion, pericardial effusion due to third space fluid loss. And then, what are the complications? The most dreaded complication is thrombosis. It may be cerebrovascular accident, renal vein thrombosis. It may be deep vein thrombosis. The thrombosis is due to loss of serum albumin. Loss of serum albumin leads to hepatic compensation, which increases the production of fibrinogen, which increases the risk for thrombosis. And also there is loss of antithrombin 3 and protein C and protein S in the urine, leads on to increased chances of thrombosis. How to correct thrombosis? We correct thrombosis by giving albumin. We should maintain albumin levels more than 2 gram per deciliter by giving IV infusions. These are clinical manifestations and complications of nephrotic syndrome. Now let's at last see what is the treatment of nephrotic syndrome. First, I'll mention the treatment in children, followed by adults. Before that, I have not discussed investigations. Investigations are the general investigations we all know. The general investigations we all know. The general investigations we all know. The urine protein creatinine ratio, urine protein level, urine creatinine level, urea, all those things you can write. And then we should write renal biopsy in steroid resistant nephrotic syndrome. Let's see what it is. In treatment, first we will give oral steroids for 6 weeks in children. I am mentioning 2 mg per kg per day, maximum dose 80 mg for 6 weeks, and then we'll taper it in next 6 weeks. After 4 weeks, we check for response. 90 to 95% of patients show remission. Remission is defined by urine albumin nil for 3 days, urine protein creatinine ratio less than through 200 mg per gram. If the patient has remission, you continue with this treatment, that is oral steroid for next 2 weeks, and then taper for other next 6 weeks. If the patient is steroid resistant nephrotic syndrome, go on to do renal biopsy. It's most commonly due to other causes like FSGS and IgA nephropathy. If there is no findings in renal biopsy, it is minimal change disease which is resistant to steroid. These then treat them with calcineurin inhibitors for 6 months, that is tacrolimus, sirolimus, or cyclosporin. If the patient shows for FSGS, that's focal segmental glomerulosclerosis, they are drug resistant one, usually we should go on for a renal transplantation. This is the treatment in children. What is the treatment in adults? In adults, investigations are same. Treatment is steroid for 1 milligram per kg per day. This session was fine. Please pause the video in between and watch. Please, if you have any doubts, you can drop it in comment section. Thank you for watching. Thank you.